Good evening, ladies and gentlemen. It's a pleasure to welcome you to today's webinar on the use of extracorporeal membrane oxygenation in thoracic surgery. It's really a pleasure to welcome Professor Olaf Mercier from Marie Lallong in Paris today, who has a vast experience on the topic, and the department is really renowned for advanced thoracic surgical procedures and the use of ECMO, and he will focus today mainly on the use in airway surgery and extended resections, and also will touch on the field of lung transplantation. And we're really looking forward to your presentation. As always, please, if you have any questions, you can place them either in the chat or in the Q&A tool, and we will discuss them after the presentation. Olaf, the stage is yours. We're looking forward to your presentation.
Thank you, Clemens, for the nice introduction. Sharing the screen. Sorry, try to. Okay, thank you. So I'll start, I've been told to talk today about the role of ECMO in thoracic surgery and more in extended lung resection for lung cancer. So I will start with a short introduction about the ECMO, which is treating hemodynamic and or respiratory failure since 1972, and the first ECMO use in the newborns. And over time, the use of ECMO spread more at the beginning of the 21st century, with three major technological advancements, which are the polymethylpentane oxygenator here, with better oxygenation and decarboxylation, heparinized tubing, allowing us to use less heparin, and centrifugal pump, moving the blood with less risk of hemolysis. So with these advancements, the use of ECMO really enlarged the field of only ICU and went to operating rooms in thoracic surgery, first in lung transplant, and then in other surgeries. A major use of ECMO was at the first pandemic of flu H1N1, and since then we've been using more often this kind of technology in hospital. And at the beginning of the 21st century, we started to use routinely ECMO system for lung transplant. Depending on the flow of the machine and depending on the site of cannulation, you may have several roles of ECMO. The first role is removing the CO2 from the blood. You can have this effect with low flow, small cannulas, mostly venous sites, and you have less complication than other sites of ECMO, other types of ECMO. The second type is a VV ECMO, veno-venous. So you are taking the blood from the vein and putting the blood back, oxygenated blood and decarboxylated blood back to the vein. It's named VV ECMO, with only venous site, cannulation site, with a flow that is close to the cardiac output. Larger cannulas, going to 20 to 30 French. In millimeter, you have to divide this number by 3. You absolutely need anticoagulation. And with this, you can oxygenate your patient and decarboxylate. So you may deal with hypoxemia. And then if you are using a VA ECMO, so you're taking the desoxygenated blood from the vein and putting back to the patient with oxygenated blood in the artery, you may deal with hemodynamic support and respiratory failure. The outflow of the machine is close to the cardiac output, and the dimension of the cannulas are close to the previous one, larger one, and you may add the complication of the arterial access in terms of bleeding and also clotting. So depending on your need, you may use the ECMO system as a system which could remove only the CO2 or oxygenate and remove CO2 to the patient, or adding to the oxygenation and the carboxylation hemodynamic support. So we started to use ECMO more routinely for lung transplants. And for lung transplant, we may use ECMO before the transplant as a bridge to transplant program in patients listed for lung transplant who are decompensated while on waiting list. We are using ECMO during the transplant for hemodynamic and respiratory support during the procedure. And we may also use the ECMO system and machine after the double lung transplant in case of severe primary graft dysfunction. And this use during the lung transplant made us realize that we could use safely this machine for respiratory and hemodynamic support with really good results. This is one example of a series of double lung transplant for pulmonary hypertension published 10 years ago from the Toronto group. And they compared a cohort of patients before the use of ECMO and after the use of ECMO. And what you see is that you decreased the waiting list mortality from 22% to 0% with the system of ECMO as a bridge to transplant with the same survival results in long term, the same post-operative and perioperative results. So this made us realize that using ECMO may help in really different problem in thoracic surgery. So reducing the waiting list mortality, but also reducing, you'll see, the use of blood products and the ICU stay. This is the second study from Toronto group, also comparing transplants using cardiopulmonary bypass and using ECMO. And what we saw is that using ECMO means that you will use less blood products, you will have a lower ICU stay, a lower hospital stay, and these are survival curves. And because of the very low number, and it's a retrospective study, you see 66 cardiopulmonary bypass group and 33 in the ECMO group, but we didn't have a difference in survival. But you may acknowledge that there is maybe a difference at the earliest post-operative period with higher mortality in the cardiopulmonary bypass group. The other question is not the use of ECMO compared to cardiopulmonary bypass, but it's the question of the cannulation sites. And in lung transplants, you may use a peripheral cannulation site, often using the groin to cannulate the femoral artery and the femoral vein, as name of peripheral ECMO. So you can put the cannula under local anesthesia. So you can start supporting before opening the chest. You don't have any cannula in the operative field, so you have a cleared operative field. You have a lower risk of air block and major bleeding because you are cannulating peripheral vessels. And it's easier to remove if you need to keep the ECMO longer, on a longer time. On the other hand, you have the risk of complication and the risk of lower limb ischemia. The lower venous drainage due to the dimension and the diameter of the venous cannula. You may have complications such as groin infection. You have a non-physiologic flow, which is a retrograde flow from the femoral artery. And in case of transplantation, you may have an hypoperfusion of the lung. On the other hand, the central ECMO, you have a better venous drainage because you have a larger diameter cannulas from the heart with better flow. No groin access, so no groin incision, no groin complication, no lower limb ischemia, and you have an antegrade flow. On the other hand, it's a central cannulation, so you may have a risk of major bleeding, a risk of air block. The same risk if you are using the VA ECMO or hypoperfusion. And you need to remove at the end of the operation the ECMO because it's quite difficult to keep the ECMO in place. So you need to remove the ECMO, to go back to the operating room and reopen the chest to remove the ECMO system. So you may have positive and negative argument to use central or peripheral ECMO. So when could you use the ECMO system outside the case of transplantation? The first indication are the airway surgery and the complex airway disease. In general, the carenal involvement, that you may avoid the cross-field ventilation. You may also use an ECMO would help in case of total airway obstruction by the tumor with ventilation and positive pressure ventilation difficulties. With ECMO system, you will avoid the cross-field ventilation, avoid the higher rate of CO2 in the blood, and you will have a better exposure and a better operating time flow because you may do the suture without interruption, and you could dissect in calm, and you may have a better exposure of the trachea. Whether you will use a peripheral or a central ECMO, or what type of ECMO should you use, VA or VV ECMO, this was discussed, but you have in the literature a lot of case series and clinical cases. So the answer at those questions are not clear today. But what we can say is that the VV ECMO today is much more used in this case than VA ECMO. So, and in my personal practice, I would prefer to cannulate inside the field to have the mean to cannulate on demand, decannulate, and have direct access to the field and have the less ECMO duration as possible. So here we are at the level of the extended lung resection for non-small cell lung cancer, and it's almost the same as the surgery for T4 lung cancers. We should differentiate the resectability, so the technical possibility of removing the tumor, to operability, which is the need of the surgeon to evaluate the operative risk of your patient and to balance the operative risk to the survival benefit of your patient. And this is the case for all T4 surgery. The balance should be very positive to your patient. So the operative risk should be as less as possible, with the most important survival benefit. And if you have this, you may think about extended resection, maybe using ECMO to remove T4 tumors. So you need to make a complete workup, and you need to know after the workup if you are able or unable to achieve a complete resection of the tumor. And you need also to assess all comorbidities of your patient. And these kind of procedures should be performed with curative intent. And this means that your resection should be R0 en bloc with free margins. And this kind of surgery should not be performed with palliative intent. So with this selection of patients, extended surgery for lung cancer requiring respiratory and hemodynamic support is of really rare occurrence. And it's around 0.5% of all the lung cancer resection in one publication in 2019. So ECMO versus cardiopulmonary bypass. With the ECMO system, you may keep the ECMO at the end of the operation if you have any issues with respiratory or hemodynamic supports, things that you cannot do with cardiopulmonary bypass. You will also have a limited systemic anticoagulation and also less important activation of inflammation pathways. And it may have impact on oncological results, but as far as we know, and it is not published or demonstrated, but we may assume that there is a difference between ECMO and CBP regarding the oncological results. On the other hand, with ECMO, you have no possibility of proximal aortic cross-clamping. I mean, on the aortic arch, you cannot have also access to open heart surgery, meaning that it's politically unsafe to perform surgery for left atrium involvement or pulmonary trunk involvement or aortic arch involvement. And on the other hand, also, you have no backup in case of massive bleeding. So when you choose to use ECMO rather than cardiopulmonary bypass for extended lung resection, you may have all these points in mind. Cannulation sites and the choice of cannulation sites is depending on the way you want to use ECMO. The most usual use of ECMO, sorry, in this case, is the use of preemptive ECMO, meaning that you will start the operation putting the ECMO on supine position, and then you will put your patient on lateral decubitus for your surgery. In this case, you may use a peripheral ECMO, using, in case of veno-venous ECMO, the jugular vein and the femoral vein. In case of VA ECMO, the femoral vessels at the level of the groin. But other solutions may exist, as putting the central cannulation during the surgery. So during the sternotomy, right thoracotomy, left thoracotomy, clamshell incision, hemiclamshell, right or left, you may choose to put the cannula on the right atrium and mixed also in the right atrium and the ascending aorta through sternotomy. You may also have the possibility to do the veno-venous ECMO, putting two cannulas on the right atrium, the one with a direction through the tricuspid valve, and the other one rather down to the inferior vena cava. So you have a lot of possibilities with central cannulation to have VA or VV ECMO, regardless the surgical approach you're using. And on the other side, regardless the surgical approach, you may use a peripheral ECMO. If you need to choose, if you want to choose to put the peripheral ECMO while on lateral decubitus, my advice is to put a catheter, because it could be tricky to put the cannula on lateral decubitus, peripheral, through the femoral vein. So it would be maybe easier if you have a catheter inside the vein to keep it and to use it while you are putting the cannula through the vein on lateral decubitus. What kind of monitoring you will use? The usual monitoring for extended resection, but you should have in mind when using VA ECMO that the pulse oximetry may be altered because of the pulsatility. On the other hand, you should put the pulse oximetry on the right arm. And almost if you're using peripheral ECMO, because you may have a not right oximetry if you are putting the pulse oximetry on the left arm, closer to the arterial cannula of the ECMO. Because you're not using a high level of anticoagulation, and if you are using peripheral ECMO, you may check the clotting of the heart and check the opening of the aortic valve and the good function of your left ventricle. And this is good to have a transesophageal echography during the procedure. If you're using VV ECMO because you're not supporting the heart, it may be useful to assess the right ventricle function during the operation using the same monitoring with the echography. Anticoagulation, usually we're using the dose of 50 units per kilogram single dose. And we are monitoring anticoagulation using all the three biological tests I just wrote in the slides. You may ask to repeat anticoagulation in case of shorter as ACT, or you may not, depending on the type of surgery you're doing. So I will be talking about the most obvious indication. The first one is the carinal resection. It's the most well-established indication, but still always case series and reports. We did not demonstrate the advantage of VA over VV, so it's depending on the surgeon. You may choose VA or VV ECMO to support the oxygenation during the surgery. What you should have as outflow for the machine is more than 75% of the cardiac outflow of the patient, or more than 50 milliliters per kilogram, to stop the ventilation and be pretty quiet during all the dissection and exposure, and then the suture of the airway. You may use peripheral central cannulation, and I talk about the catheter on the femoral vein if you're doing the peripheral cannulation side. The other indication is the descending aorta involvement. And you see a picture of the aortic arch, and here resection of the part of the wall of the descending aorta. You may use here the ECMO with peripheral cannulation, meaning the ECMO can perfuse down your aortic cross-clamping the abdomen, and the heart will perfuse the upper part of the body. And with this, you can cross-clamp the aorta on both sides of the tumor, and then remove the wall, involved wall of the aorta, and do a R0 resection. So it's always a VA ECMO you should do, peripheral flow monitoring, 50% of the flow at the level of the abdomen and the level of the ECMO, 50% of the flow by the heart on the upper part of the body. This technique should be compared now with a new technique, avoiding the use of ECMO and using aortic endograft. This has been published, putting the endograft before the operation and then doing the surgery with the resection of the wall. What we should not perform on ECMO, this is the first example I told you about a few minutes ago, is the left atrial involvement with the tumor inside the left atrial. With the ECMO system, you cannot open the left atrium and be sure that you are away from the tumor while you're resecting the left atrium. So this is something you should perform more safely under cardiopulmonary bypass and aortic cross-clamping. The pulmonary trunk, also one example of one proximal left tumor invading the left main pulmonary artery and the trunk distally. With this, you need also to open the trunk and repair and patch or replace the pulmonary trunk, and this is something you may do rather more safely with cardiopulmonary bypass. This is the survival curve of all the T4 surgery with in this the Marina Long experience of T4 surgery, more than 300 patients, 374, with almost 40% at 5 years and 26 at 10 years. This is a high selected population, as I told you, but this is a result that is quite interesting. We don't have the series of ECMO system, but using the cardiopulmonary bypass, we didn't find any difference in survival between the use of cardiopulmonary bypass and the T4 surgery without cardiopulmonary bypass. This we may see in the next future when we will collect all the information on our surgery on ECMO, maybe a difference in survival in patients with ECMO rather than cardiopulmonary bypass. But this is something I cannot tell you today. So as conclusion, you see that the ECMO could help in rare and complex cases of extended resection for lung cancer. Further studies are really needed to confirm oncologic results from case series, and this may be done by multi-center studies due to the rarity of the cases. Impact of the type of heart and lung support on oncological research should be studied, and the use of ECMO for extended resection requires routine use for more frequent procedures, transplantation, ARDAs, in experienced team. And I really thank you for listening me, and I'm really open to discussion, Clemens. Thank you.
Yeah, thank you, Olaf, for this nice overview on the use of ECMO in lung cancer resections and also in lung transplantation. You showed a lot of different possibilities for cannulating ECMO. There, particularly in the VV ECMO, there are several double lumen cannula devices available, which are broadly induced. What's your opinion on that? What are good indications for that, and what's your preferred cannulation site for these?
So yes, the issue with the double lumen cannula Avalon veno-venous is that you are limited in the outflow of the cannula. So you have to make sure that with your Avalon, you may reach the 75% of cardiac output of your patient. Because if not, you will not oxygenate your patient, and you may not have the possibility to stop the ventilation. This is the most, I think, important issue with this kind of approach. On the other end, when you're using a VV ECMO with 2 cannula or 2 cannulas in central cannulation in the right atrium, you are sure that you will have a really nice flow and a flow level that will allow you to stop the ventilation. And this is something that is pretty nice. But if you're sure that you may stop the ventilation with a double lumen cannula, you may use it, yes. The other issue with the Avalon cannula is that the placement of the cannula is pretty tricky. And with the position of the patient, you may have a different positioning of the cannula, and the oxygenation may differ. So I think the VV Avalon cannula or double lumen cannula, it's quite tricky to use it. And I would use more largely the central venous cannula in my experience.
Do you use any other double lumen cannulas, like there's the Crescent or other, there was the Novaport Twin? Do you see any differences between these double lumen cannulas and the technical aspects when positioning them?
Yes, so you need to put the Novaport, this kind of cannula are really nice to decarboxylate, but quite difficult to oxygenate in total your patients. I mean, you can have the double lumen cannula Novaport or Avalon to at the end of an ARDS in the ICU, but your patient is still recovering from the lung, and they may need additional help to oxygenate. But it's very difficult to have a total oxygenation with double lumen. It may not be impossible. With the Novaport, you have no direction of the oxygenated blood to the right ventricle. So it's a mixed venous blood oxygenation. It depends on the possibility to reach the 75% of cardiac output. For the Avalon, the placement, you need to place the ejection hole of oxygenated blood in front of the tricuspid valve. So you may control the positioning of your cannula with echo. So it's pretty complex. I would prefer, in my practice, to use the 2 different cannulas of VV ECMO to be sure that there is no misplacement of the cannula, to be sure that I will have enough outflow and oxygenation of the patient, and with no problem during the surgery when the trachea is open, when you are doing the suture, you have no issue with this.
So when you're using 2 cannulas, one of the potential issues is that you might have free circulation if the tips are too close to each other. What's your preferred cannulation site, and what measures do you take to avoid this problem to occur?
So in peripheral, you mean? So in central, you may put the cannula in different direction. One cannula directed through the tricuspid valve, and the other one through the inferior vena cava. With this, you avoid the recirculation. For the peripheral, you may introduce your femoral vein cannula at the level of the sushepatic vein, and the injection cannula just at the level of the end of the superior vena cava. And with this, you have space between both cannulas, and you may avoid as much as possible recirculation. And you may look at the color of the blood inside the tubing and correct the position of the cannula if you think you have a recirculation.
You've nicely showed an overview what types of ECMO can be used for what type of tumor resections and when ECMO should not be used. When we're talking about, for example, for carinal resection, you've mentioned that to prefer cannulation via the operative site. What's your favorite approach? Do you rather use veno-venous or veno-arterial in this indication?
Yes. I like veno-venous when I know that it's only the airway that is involved. When if you need to if you have the thoracic aorta involved or something more involved, I would prefer VA ECMO to have the hemodynamic support with the respiratory support. The barrier between ECMO and cardiopulmonary bypass should be really well assessed before the operation. You may switch from ECMO to CBP if you have misunderstood the preoperative imaging, and you may discover involvement that you may not noticed before the operation. But clearly, I would prefer VV for strictly respiratory problem, airway involvement. VA when you have something else involved that could be dealt with the ECMO system. And if not, it would be the cardiopulmonary bypass. I mean the left atrium or the aortic isthmus with the left subclavian artery. I would use the cardiopulmonary bypass.
We've been talking a lot about the intraoperative use of ECMO. You've showed several parameters that can be looked at when monitoring the anticoagulation status during ECMO. These are all, of course, very important if you have a longer run on the ICU. For the purely intraoperative use, there's little evidence on how the anticoagulation actually should be dealt with. The systems in use are all heparin coded. So what's your strategy if you're using ECMO purely intraoperative? Do you do any monitoring of these coagulation parameters, or do you just give a standardized dose and then forget about the rest?
So we are using the standardized dose, single dose, 50 milligrams per kilo of heparin, but we are using such as cardiopulmonary bypass and like heart surgeries, the ACT. But we are not adding more heparin during the surgery. It's a single dose. So we are using ACT just to be sure that the heparin was inside the body of the patient, just that there is no issue with the injection of heparin. But it's not something that will do no other dose of anticoagulation during the surgery, because we're just using the ECMO in an acute purpose, just to make the surgery, make the resection, and then you have the weaning of the ECMO. So it's just a single dose ACT at the beginning to be sure that the heparin was inside the patient, and then no other anticoagulation. I cannot tell that this is something that has been demonstrated, but I've been using this in every cases, and I had no problem. But I cannot tell if we compare or if it's the right way to do, because it's not demonstrated, but it is the way we are doing, and it's working well. Once you have a correct flow through the machine, more than 2 liters per minute, with the heparinized tubing, I think you can and never saw clotting of the system within 4 hours while you had the single dose of heparin and you're running at more than 2 liters per minute. So it's pretty safe. It may be different if you are running at lower flow. If the patient has a problem with clotting or with anticoagulation, I don't know, but usually it's a single dose of heparin and then nothing more.
So what would you do if the ACT was just under 20 or something?
Yeah, just checking that where did you put the heparin? In the IV line, which one extra? I will put maybe myself the heparin through the right atrium. I would check if there is something with the heparin. It's just a question of to be sure that sometimes we had the problem with IV line. With the IV line wasn't inside the vein, but rather in the subcutaneous tissue, and the heparin wasn't in the vein of the patient. So we saw that. So we add a new IV line to the patient and get a nice anticoagulation. It's just a quality control of the anticoagulation prescription. It's just something like that. Nothing more.
Okay, so you mentioned the minimum flow you're aiming for is 2 liters per minute.
I think so. Yeah, 2 liters. But this is also experience and like expert advice. It's not like demonstrated. It's not like if you have 1.9, it's a nightmare. But usually around 2, it's a good flow for the machine to avoid clotting.
If you're doing a procedure where you anticipate that only intraoperative use of ECMO is required and you're aiming for winning at the end of the procedure, do you always prepare the groin or have the groin sterile just in case anything happens? Or do you think that's not necessary?
That's absolutely, you're right. The groin should be on the operative field. Yes, absolutely. This is really good practice.
And in case you require post-operative use of ECMO, do you always switch to the groin, or are there some indications or considerations that might prompt you to leave the patient centrally cannulated?
It's a really good question. So it's more for transplants, because for lung cancer surgery, it's really the use of the ECMO as a support during the resection, and the weaning is usually not the problem. But if I would have any problem with this kind of surgery, I would rather switch by peripheral groin to close correctly the chest and then remove secondarily the ECMO. For transplant, it's a difficult case. The decision depends on the bleeding and the probability to come back to the chest to remove clots. If it's not bleeding, I would switch from central to peripheral to close definitely the chest and then just win the peripheral part of the ECMO. But if you know that the operative field is at high risk of bleeding and clotting, and you need to left open the chest, I would keep the central cannulation and then remove the cannulation in the OR at the time of reoperation. It's like more practical in my point of view.
You mentioned the field of lung transplantation, which is, of course, a different one compared to tumor resections. In lung transplantation, there are two general concepts of intraoperative ECMO. One is more or less to use it in every case, and very low PGD rates have been described with that. And other centers have more use of a policy of using ECMO only if it's required, either by hemodynamic or respiratory measurements. Do you have any considerations on that you want to share with us?
Yes,
What policy you're using?
absolutely. So we have a third policy, which is putting a left atrial catheter to monitor the fluid level of the patient. And with the value of the pressure of the left atrium, you know if the patient is that you can wean the patient from the ECMO at the end of the operation, and you may follow in the ICU the perfect fluid level of your patient to avoid the need of ECMO. And if you do not succeed in having a low left atrial pressure, you know that for sure you will need ECMO. So we are using this kind of catheter to decide weaning ECMO and it's okay in the ICU, or keep ECMO, go back to the ICU. This is our policy. And with this, we have 98% of successful weaning of ECMO at the OR for the transplanted patients.
But did I get it right? You're using ECMO in every patient you're transplanting?
Yeah, because we are transplanting 80% of pulmonary hypertension. So we are using ECMO quite a lot, even maybe in every case, but it's like a center specificity, right?
Do you think there's any minimum threshold on the number of ECMO runs a center should do annually, or is there any evidence how the frequency of ECMO should be in order to achieve reasonably good outcomes? This is, I think, of particular importance for centers who are considering to start up an ECMO program, to know what the requirements are and what a good policy on that might look like.
It's a really good question. I think I don't know exactly the number we should advise, but it's the number you are comfortable with the technique. And all the team also, because it's not like a question of one man. You know that when you're putting ECMO, you have perfusionist, you have anesthesiologist, you have surgeon, you have intensivist, you may keep the ECMO. So it's all the team, and you should used to using this kind of material. So I would say, I don't know exactly what the number, but for sure you need to do it every year and several times a year. So I think less than 2 per month is 24. I would say yes, 30 a year, 25, 30. Below the 30, below 2 cases per month, it will be difficult to use it like usually in the OR. I don't know what you are thinking about, Clemens, about the number. I would say 30 to 50 a year.
Well, I think there's no evidence really that a certain threshold can be defined. It's really a matter of routine, and probably a lot of centers will have difficulties achieving a number of 30 to 50 runs a year. So probably if you really want to start up, aiming for at least 10 to 15 runs in the startup phase to get a certain routine in it would be probably absolute minimum number, I think, to achieve a sufficient experience in the team, because otherwise you're always starting from the beginning on. And of course, if you have some programs in the hospital where ECMO is routinely used and the entire staff is trained on it, and that's a completely different situation than if you have to train an ICU team, for example, completely new. If you, for whatever reason, require not just intraoperative use, but the use on the ICU, they really need to be acquainted with the system and with all the details. You mentioned the perfusionists as an important part. I think it's no doubt if you're using VA ECMO or more complex procedures. If you're just doing veno-venous, there are some centers which are using ECMO without a perfusionist. Do you think that's a valid approach, or do you think that's something that's absolutely required?
It's always the same. I mean, you never know if you will have trouble. It's like a question of troubleshooting during the operation. Problem with the ECMO, or needing to switch from VV to VA for any reason, or VV to other type of support. When you're using support, it means that you are close to the line. I mean, you need to think about which trouble you may need to deal with. So this is maybe the reason why I would recommend to have a perfusionist at your side. But it's not like behind you and waiting for you. I mean, in the OR, you need to have the perfusionist that may stop what they are doing and get to your OR to help you if in case of problem. But I would recommend to have an access to. It's not because you're sure 100% that you may do the surgery on VV, yes, but you never know the problem that you may have.
I fully agree. I think it's important to have a perfusionist at least in the backup. That's an absolute requirement. There was another question about recirculation while using double lumen cannulas. Is this something you experienced? And if yes, how would you correct it?
So the recirculation or the
recirculation when using a double lumen catheter.
So with the Avalon cannula, it's really the role of the echography that you should really put the injection hole in front of the tricuspid valve. You may have a huge difference in oxygenation if your cannula is misplaced, and it's pretty tricky, and it's pretty hard to keep the position, the correct position of the cannula if you're moving the patient. So this is an issue with this kind of cannula. With the other double lumen cannula and the Novaport one, for example, it's not so dependent of the position of the cannula, because the injection is like 36 degrees, 360 degrees, sorry. So it's not a question of position, and I'm not sure that you have so much recirculation with this kind of cannula.
Maybe another technical question. If you're doing central cannulations, what's your preferred type of cannula you're using? And the way of implanting it, do you use Seldinger technique for the aortic cannulation, or do you use a different technique?
Yes, so I'm using the cardiopulmonary bypass technique. So you're putting the purse on the ascending aorta, opening with a scalpel, and then putting the cannula inside the artery. For the right atrium, or for the venous cannula, it's also a purse inside the right atrium, and then putting the cannula inside. If you are on the left side, I would use the femoral vein, or you can also use, but it depends the type of surgery you should do. But I may use the femoral vein usually, rarely the pulmonary artery, but the femoral vein and the femoral artery on the left side. On the right side, I use the right atrium and the ascending aorta in the cardiopulmonary bypass fashion.
Yeah, you're preferring straight or angulated cannulas for the venous cannula?
Straight cannulas.
Straight cannulas.
Yeah.
Okay. Well, so if there are no more questions coming from the audience, I think we really had a good overview on particularly the intraoperative use of ECMO. So maybe regarding the prolongation of ECMO in the postoperative course outside the field of lung transplantation. Do you have you experienced situations where the patients in extended resections, airway surgery, could not be weaned from the pump as anticipated? And do you have any special considerations on when to prolong ECMO in this situation or not?
I did not have any cases that could not be weaned after airway repair or airway surgery. But it's like elective case for lung cancer. It's not like trauma or traumatic airway repair. It may be differ in trauma with the additional maybe lung parenchyma trauma. It may be different in this case, but in the lung cancer elective surgery, I didn't have the case that you could not be weaned from the machine.
Okay, this is also my experience, and I think that's something that should be taken also as a measure. If you're doing elective surgery on ECMO, you should really perform the procedure in a way that the patient actually can be weaned from the ECMO at the end of the procedure. Might be different in patients, for example, with tracheal lacerations, if you're having difficulties with the oxygenation and require ECMO, which is rare cases. Yes. But there you might encounter some instances with an ARDS-like situation. So we've come to the end of the webinar of the hour. So once again, thank you, Olaf, for this really nice overview and for sharing your insights. I'd like to invite the audience also to register for next week's webinar, which will be an AstraZeneca-sponsored webinar on the topic of perioperative immunotherapy and lung cancer surgery. And with Jonathan Spicer and Martin Schuler, we really have also very renowned speakers. It will be next Wednesday on the 20th at 6 p.m. and I would look forward also to see many of you there.
Thank you, Clemens, for the invitation.
Thank you, Olaf, and thanks for the audience for participating and for the good discussion and the questions.
Absolutely. Good evening.
Good evening. Bye-bye.
Bye.